Good morning, Bangkok. How's everyone doing? Yeah? All right, wonderful. So pleased to be here, and I want to start off by thanking the Deputy Prime Minister and Mahidol leadership. This is just such an incredible opportunity for me. I put together a very ambitious presentation here, so I'm going to try to do my best to pace myself. And when we have live translators, typically I will go through at least 3 or 4 in a typical presentation. Dean Pat can attest to this. So I'm going to try to slow myself down, which is very difficult for me. But I can't wait to get started. So we've prepared a presentation on AI-driven innovation and the role of academic health systems. Okay. So I do have to disclose some conflictual interests here. This is just housekeeping for us in the United States. I participate deeply in a number of grant programs funded at the federal, state, and municipal levels. I do a lot of technology advising, and I serve on 6 or 7 boards of directors, as you can see delineated on the slide here. Okay, and I would be remiss if I didn't start off with a very special acknowledgement for some incredible collaborators that I've been working with now for almost 10 years. So it's been a wonderful collaboration. I'm very pleased to report that we've brought in close to, I guess the equivalent would be 180 million baht in terms of research dollars, which has been really the privilege of a lifetime. So I can't thank these 4 individuals enough, including some students that we have here who've really helped make this work possible. Okay. So I have a very ambitious agenda, as I mentioned at the top of our hour here of 45 minutes. I'm not going to go through all of these topics now, but we're going to touch on each of these themes. And we're going to start off with touching on this historic inflection point that we're currently living through. So I want to pause and talk about the proliferation of artificial intelligence. AI is everywhere. And there have been unprecedented uptakes of all of the AI tools that we now know as sort of commonplace technologies. So here's a really interesting schematic from a business journal. On the left-hand side, you could see the amount of time it took to reach 1 million users. And I'm sure many folks in this room know Netflix. By round of applause, folks know Netflix? Yeah? Okay. So Netflix took 3.5 years to reach 1 million users. That's 3.5 years. ChatGPT, 5 days. So it's really incredible how quickly these AI tools have been adopted. And what's really interesting is on the right-hand side, so we talk about the relationship to economics. And on the right-hand side, you can see the growth rate of the market size for artificial intelligence. And on the right-hand side, it may be difficult for you to make this out, but it's a $1.5 trillion market size by 2030. I just want to pause on that for a sec. $1.5 trillion, so really, really incredible. Okay. AI and healthcare, front and center. The next 5 years is going to be one of the most transformative periods in medicine over a century, likely comparable to antibiotics, medical imaging, and the internet revolution. And AI, we have to admit, is here, and it's shaping virtually every aspect of healthcare and well-being. Whether we're talking about communication, whether we're talking about healthcare, or whether we're talking about mobility and participation, which is really important to me as a disability expert. Okay, so let's talk a little bit about artificial intelligence behind the scenes. AI really requires us to rethink about how information is generated, organized, and accessed. We have evolving workflows in healthcare work to improve healthcare efficiency and outcomes. So let me give you some 4 examples. We could talk about the automation in data entry, generating suggestions based on medical records or genetics or prior treatment responses. We could talk about managing AI assistants to augment and not impede clinical skills. This is a big problem right now in the United States, and we're talking more about the use of AI and what's happening in different medical areas, including cognitive de-skilling, which is a concept that may be new to y'all, but I'm happy to talk about it more later today. And we must be very cognizant of the weaknesses of AI. Some of the pain points include inaccuracies or the sort of famed hallucinatory issues that we talk about. The inability to handle specific data types is a big problem. And lastly, privacy, HIPAA concerns, right? Okay, so let's talk about directed innovation and AI now with purpose. So how to innovate with AI? Number 1, let's start with the problem and not the technology, which is a big mistake a lot of us make. I'm guilty of it myself. We have to identify meaningful clinical, operational, or equity gaps, and we have to focus on unmet needs rather than AI capabilities. We want to build evidence before scaling. Very, very important. We want to move beyond proof of concept and validate in real-world clinical environments. And we have to measure safety, effectiveness, usability, and adoption. We'll talk more about implementation science later in the talk. Critically, we have to keep humans in the loop. We need to augment, not replace, clinical judgment. We need to use explainable AI approaches that don't live within black boxes. And we need to build systems that clinicians and patients can trust. It's a really important aspect. And we have to measure what matters: clinical outcomes, patient experience, health equity, and workflow efficiency. And I want to emphasize the patient experience piece, because we really have to think about the patient journey from the minute they leave their house or their domicile all the way to what we say in the United States, they get their butt on the exam table. We want to understand every single aspect of that healthcare journey. Okay, so where to innovate with AI? Well, healthcare cannot innovate simply because we can. We have to have innovation that's aimed and directed at meaningful problems, like accelerated drug discovery, real-world participation, for example, patient scheduling, independence and accessibility, for example, translation and captioning apps, and lastly, human capability. We have to talk about supporting patient memory and comprehension, or supporting clinician work through AI suggestions and flags. We often call these BPAs, or best practice alerts, if you use that terminology here. Okay, what are some of the concerns? AI can improve healthcare access, but it can also deepen inequity. This is something we're talking more and more about in the United States, and I think it's very relevant here in Thailand as well. AI systems can reflect the data, assumptions, and context used to build them. So oftentimes we end up with AI that's biased based on those incomplete data sets. We have tools that may fail if they are designed without understanding the wider context or the clinical workflows that they're being utilized within. We have benefits that may be concentrated among clients or communities that already have resources, creating deeper inequities. And very importantly, academic health systems must help direct innovation responsibly. And we're going to talk more about this later at the end of the presentation, which was a theme I was supposed to hit on this afternoon or this morning. But we need to use research to identify and understand key areas and challenges. We need to validate in applied settings. We need to develop stronger standards around safety, performance, and accountability. And lastly, we need to ensure equity in both the development and testing of all and every solution. Okay, so let's talk about unlocking infrastructure with AI and assistive technology, my favorite topic. Okay, let's start off by briefly reviewing disability as it relates to healthcare utilization. Well, first and foremost, folks with disabilities or chronic illnesses have higher hospitalization rates. They have higher emergency department utilization. They have higher rates of preventable admissions. Important topic in the United States right now, and I'm sure also applicable to Thailand. Assistive technologies can bridge gaps in healthcare access, but there is a dire shortage. So if we look across the globe right now, there's 1 billion people in need of one or more assistive products or technologies. With aging, we can expect greater than 2 billion people will need these assistive technologies by the year 2030. Now here's the kicker. Today, only 1 in 10 have their needs met. 10% of the population. That's a 90% shortfall. It's very important that we focus on this. This is probably the most important point of the entire talk. Okay, and you may only think that healthcare is the most important topic, but it's not. If we look at employment, the employment rate is lower for persons with disabilities. Educational attainment, drastically lower in persons with disabilities. If we look at poverty, poverty massively increased in persons with disabilities. Cost of living, more difficult. Transportation, this was included in a health equity report published by the United Nations. There's a 15-fold difference as it relates to transportation and affordability. It's a 15x difference. I mean, massive differences. Okay. And I want to remind everyone that based on the new CDC data, the Centers for Disease Control in the United States, we're approaching 1 out of 3 individuals or U.S. adults living with a disability. 1 out of every 3. much more common than we previously thought. Okay, and it all stems from information access being the key. Accessibility barriers are very often rooted in unequal access to information. Second most important theme of this morning. Sensory cognitive and language barriers frequently become information access barriers. Information may exist, but it remains inaccessible because it is visual, auditory, complex, poorly structured, not translated. Yet, AI-enabled assistive technologies can be that information equalizer. AI/IT can unlock access to existing info rather than building new infrastructure. The goal is not to build separate worlds, but to build a shared world. And I know there's a new point of interest in universal design, which is being built into new legislation with some discussions we had with the Deputy Prime Minister this morning. Very exciting work. Okay, so let's start talking about the problem space, and then we'll get into some solutions and problem solving thereafter. So let's talk about information access management. So there are many types of AIs that can do all sorts of really interesting things, as you can see on the left-hand side. But I would argue that right now AI is providing a lot of information and unfortunately is doing a poor job at filtering that information to providing meaningful feedback to the end user. Assistive technologies must provide the right information at the right time in the right format. I can't stress this enough. It's very, very important. And here's another really interesting thing about assistive technologies. Right now, it's serial information access. So present state, AI and AT offers a plethora of tools, but they can only be used one at a time. So as you can see in this schematic on the left-hand side, there may be 3 tools available, but I can only operate them in series. Now let me juxtapose that with a future state where I have that same plethora of tools, but I can agilely and intelligently use all of them at the same exact time or concurrently. Wouldn't that be interesting? So rather than having a ping pong between different applications and features or modes in those applications, what if I could turn all of them on at the same time and figure out how to support that? And we're going to talk more about that later. Okay, enough about the problem space. Let's talk about how we solution. So what about more modern and contemporary platforms for parallelized AI? So I'm talking about novel application architectures that allow multiple AI microservices to be run together in parallel rather than in series. I'm going to stress this concept of platform technologies that provide a foundation for hosting, scaling, and updating these AI-based microservices. And then finally, there's an AI intelligent orchestration layer that oversees an ensemble of microservices that can be loaded based on end user need. Okay. We also have to talk about how we're shaping AI output. Output needs to be more intent-aware, intent of the end user, and also context-aware depending on the environment that I'm currently situated within. Okay, so what's a good example? So everyone's familiar with optical character recognition here, okay? So let's say this is one of my blind colleagues who happens to be using the Meta Ray-Bans, okay? He's at a restaurant, he's reading a menu. Now, I happen to know that this end user happens to be a vegetarian. So should that optical recognition read the entire menu, or should I only read the vegetarian options that are pertinent to his selection? I think we would pick the latter, right? We're not going to do audience participation right now. But we would want to pick the latter. That's really important. So rather than wasting his time spending 5 minutes reading the entire menu, I can agilely negotiate the 4 vegetarian options, and what previously took 5 minutes takes 10 seconds. Okay? This is a big difference. And here's a really important point that I also want to stress. Persons with disabilities often experience the future first, before everyone else. So when access to information, communication, and mobility depends on technology, the disability community feels that dependence earliest. So for persons with disabilities, AI-enabled assistive technology is essential infrastructure. It is not a convenience. I hear this all the time. This is not a convenience. It's critical participation infrastructure. Innovations created to address accessibility needs often reveal solutions that benefit everyone. We call this the curb cut effect. So what are some examples? For folks who don't know curb cuts, these are the little cutouts on the sides of the street. So I can ramp myself up instead of having to step over that curb barrier. What about captions, which have become mainstream media? also created in accessibility labs, or speech to text, which is really important for dictation services, or lastly, image descriptions, which are becoming extremely popular, okay? Disability community experience it first. Now let's talk about navigation, meaning participation. We say this all the time in my lab. If you can't get there, you can't participate. I'm going to say that a second time. If you can't get there, you can't participate. I'm going to show you some really interesting data that was just accepted for publication in a moment. Our lab focuses a lot on visual impairment for obvious reasons, with myself being legally blind, secondary to a retinal dystrophy, and its impact and how we can solution for the barriers in the built environment. But visual impairment amplifies all of those utilization barriers and those social disparities that I talked about earlier. Employment, healthcare access, education, independence and quality of life, community participation. It's all there, okay? So let's talk about a daily commute. So these are actually photos from my private iPhone to give you an example of one day in my life in New York City, okay? Let's start off with some narrow paths. These are sidewalks that I have to negotiate right next to the hospital. So you can see all of these tree pits, or these random construction ramps, or random furniture that happens to be placed there by the janitor for a building. Let's talk about random obstructions, like ambulances that are blocking the zebra stripes for crossing the street, or trolleys, right? Package trolleys that are used by delivery persons, or scaffolding, which is another problem I can't tell you how many times I've walked into. And lastly, random construction hazards. On the right-hand side, you can actually see a pit that was approximately 15 feet, 5 meters deep that I almost walked into because the attendants weren't paying attention. This happens almost every day in my life in New York City, okay? Let's talk about navigation challenges more broadly for the visually impaired community. Up to 87%, that's almost 90%, are not comfortable navigating indoors, above and beyond what I just showed you in outdoors. In fact, approximately 75%, that's 3/4, say navigating hospitals is particularly difficult. So this is a problem when we think about healthcare access, right? And there are a lot of issues with disorientation, inconsistent layouts, wide open areas, too much noise, too little noise, brightness, shiny surfaces, lack of health, crowding. This is a beautiful building we're in right now at Digital Park. But notice that every color that's used is gray. Gray walls on gray floors, on gray backgrounds, on gray furniture, and it's extremely difficult to negotiate, particularly for someone who's low vision, okay? I could help design the future digital park if they're interested. Okay. So let's show you some data. We talked about data being important in the first panel. So here's a head-to-head comparison. It's an indoor navigation exercise where we took a new lab member who was visually impaired, and we compared his performance to a new lab member who was not visually impaired. And the goal was simple. We want you to find our lab. And we gave them a floor plan that they could use on a phone with all of their own accessibility preferences or standard features on their iPhone. So we have a simulation here on the right-hand side of what it's like to look through the visual impairment of this new lab member. And on the opposite side, you can see what it was like for the individual without the visual disability. So I'm going to play this video briefly. This is actually one of our hospital buildings in New York City on the east side. And you could see on the left-hand side, the lab member without the visual impairment, and again, on the opposite side, the lab member with a severe peripheral field restriction and some central loss as well. Okay, I'm not going to play this entire video in the interest of time, but I'm going to show you a second video where the chaperone or the instructor was shooting film of those lab members. So now you can see what their journeys is like. Again, on the one side, we have the visual impairment, and on the opposite side, we have the lab member without the visual impairment. Now, I'm going to speed this up as well, because I don't want to play this entire video clip, but you could see the lab member without visual impairment took approximately 30 seconds to complete a 30-meter journey. On the right-hand side, the new lab member with a visual impairment took 215% more time, that's 104 seconds, and walked 150% more in terms of meters, okay? So 71 meters compared to 30 meters. Massive differences. Okay. This is what the trajectory looked like for these individuals. Okay, so you could see huge differences, and it makes perfect sense why it took longer and required more distance Okay. Here's another example that I wanted to highlight in an outdoor space. So we took about a dozen blind individuals. They were at a nonprofit that we've partnered with in New York City, and we asked them something simple. We want you to get to the closest subway station next to the front entrance, okay? It's a half a mile there, a half a mile back. You have to go through 3 different intersections. It's approximately a 6-block journey. And then we compared it to those without visual impairment. I'm not going to go into all the specifics in the interest of time, but here's what we saw. So if you were to complete a half a mile journey to the subway station, it took the group without visual impairment approximately 9 minutes. And then we separated the group with blindness into a peripheral field loss bucket and a central field loss bucket. And then we compared their performances. So you could see on the graph on the left, the group with peripheral vision loss took 31% more time. It's approximately a 3-minute increase for that half a mile journey. Whereas the central vision loss group took an additional 20%, or approximately a 2-minute increase. Now you may be saying, JR, those differences don't really matter. 2 minutes, 3 minutes. Well, here's what's interesting. A typical commuter in New York walks, on average, 6 miles. So if I take this deficit and I multiply it by 12 for the daily difference, guess what I end up getting? For peripheral field loss, it's 35 minutes per day. For the central, it's 25. Now, here's where it gets interesting. If I extrapolate that one step further to a week, the group with peripheral visual impairment is losing 4 hours of their working week. That's a half of a workday, given these navigation inefficiencies. Central vision loss is losing almost the same at 3 hours. This is unsustainable. So it's no surprise that when we look at employment for different disability groups, how can they deal with these barriers, right? It's no surprise. This is all published, and these publications are available to you, and we could work with you to get them, but there's a bibliography and references, and all of these slides are available to everyone who's participating in the conference. Okay, so let's talk about some of the current applications for information access and navigation. Current assistive apps do make information and navigation more accessible. On the left-hand side, you could see Microsoft Seeing AI. Very common, in fact, probably the mobile application that's most broadly utilized across the globe. On the right-hand side, you could see a company called Navalens, which creates these colorful QR codes, which are used for wayfinding. But here's the problem. Some of the same themes we talked about earlier. Single action along with information overload and poor filtering. And I'll show you more on that in a moment. Generic information, often unfocused feedback without considering users' needs. A lack of context, limited interpretation given a lack of germane information. And lastly, error state mismanagement. This is really important, and for the user experience engineers in the room, this is a concept that is talked about frequently and really important. Okay, so now let's get to the fun. Directed innovation in assistive AI applications. And I'm going to provide, I didn't have as much time as I would have typically liked, but we're going to give you a brief showcase of 3 of the microservices that we've developed over the last decade. The first one has to do with wayfinding in both indoor and outdoor environments, tackling what we call in urban science, the first mile and last mile challenge. The middle one, which I'll talk about second, is a concept called Commute Booster that we developed for middle mile navigation. This is navigating your SkyRail, for example, or navigating your subway. This is how do I negotiate that built environment as it relates to the station itself and the trains themselves. And then lastly, we're going to talk about AI performance enhancement. This is not a drug. This is how we can make AI more potent. So pay attention to all 3 of these. Okay, first we'll start off with UNAV. I'm going to do a very brief 10,000-foot overview of how UNAV works. This is some work we've partnered with Mahidol University on. It's very exciting. But we have a smartphone application that allows us to take photos, which are acquired with these 360-degree cameras. These are GoPro cameras, which you can find on Amazon for about $200. And we walk around all of the hallways in the place of interest. So as fast as you can navigate each of the hallways, you can map that environment. Then we have an agile georeferencing process, which is the equivalent of what GPS provides outdoors for the indoor space using 2D floor plans and a couple of fast measurements, which if you're interested in, we could talk more after the conference. And then we create this lightweight digital twin that we call a topo map, or a space topology map. short topo map. And here you can see the point cloud with some trajectories integrated into those point clouds in a GIF spinning around. Okay, so let me put this all together. So now I've done the pre-mapping, I've spun up my topo map. You take a mobile application, so a patient going to visit Golden Jubilee Hospital, for example, can download this app with a QR code or with a digital push, and then they open the mobile application, and there's two different versions of UNAV. There's the core formula, which basically localizes the end user and then provides routing overviews. And then we have the Pro, which provides step-by-step guidance. I'm going to play videos of each. So we'll start off with UNAV core. So this is an end user opening the mobile application. They're going to take a photo. They're typing in their current location. They're picking a destination. That was the photo being acquired. And almost instantaneously, you can see the current origin in green and the blue routing information that's provided to that end user. Now, we have accessible versions of this for folks with visual impairment or visual disabilities and cognitive disabilities, but this is really exciting. So to take that one step further, we have UNAV Pro, which I'm going to play now.
You selected ADA restroom.
Now in the bottom right-hand corner, you can actually see the live video feed from the phone itself.
5 meters ahead.
And you can actually see an augmented reality overlay to provide the pathing information that's needed for the end user. But we're basically given step-by-step verbal and tactile guidance to this end user. Some really, really exciting work. Okay, if we have time at the end, I'm happy to go back to those videos. So I'm thrilled to report that we just finished our second clinical trial in partnership with Mahidol University, which was in essence designed to be a clinical validation of UNAV working in multi-floor navigation, or what we often call MISO, or middle-level navigation. So you're in the same building, but you're navigating between two floors. It's a very standard journey for most of us, right? I walked in the ground floor of this mall. I needed to get to the third floor to participate in this conference. Same sort of thing. We did this at a healthcare center with 3 different floors. It was designed as a within subjects non-inferiority project. There were 30 blind and low vision participants, average age 30, 10 female, 20 male. And there were 3 conditions. We had UNAV, which we call active support, and then we had 2 reference. We had a standard in-person travel direction offering, which was a receptionist or a security guard basically telling you where to go, step by step. And then we had a video call, which was a remote interpreter, which is sort of a de facto standard in the blind and low vision community, used a lot in the United States in airports and malls, amusement parks, etc. Across all the routes, the average distance was between 250 meters to 400 meters. And again, you had to span 2 floors, and on average, there were 4 turns that needed to be made in order to complete your journey. On the right-hand side, you can see some photos from this work being done. Very exciting. I'm not going to have time to go into all of the results. We're still processing the data, but I wanted to share a little sneak peek in terms of the performance. So here you can see UNAV, the active support in blue, the standard in-person travel directions in green, and the video call in yellow. Bottom line, journey completion time, much better for UNAV. What about obstacle contacts? Least for UNAV. What about interventions required from the chaperone? Smallest amount for UNAV. What about how many times the end user stopped, or what we call idle or dwell period? Again, very good performance from UNAV, similar to standard in-person travel directions. What about the number of help requests from the chaperone, meaning the end user had to request help verbally in order to figure out their next step? Very low, almost minimal for active support in a UNAV. And for journey success rate, perfect performance for UNAV. Bottom line, UNAV works really damn well. Okay, let's talk about Commute Booster. How am I doing on time? I have 15 minutes left. Okay, I think I'm doing well on time. Now we're going to talk about middle mile navigation. So this is our Commute Booster application, which is currently being reviewed by the Metropolitan Transportation Authority, the biggest transportation authority in North America for adoption in their mobile application. And we're going to talk about how it works and then show you some snapshots for a clinical trial that was just submitted for publication. So the goal here is we wanted to spin up a mobile application that leverages existing infrastructure. So one of the highest sort of performers in the world of AI is optical character recognition, right? Probably 95% to 98% accurate, depending on the model that you're using. And we wanted to leverage, again, existing infrastructure in the subway network for the MTA. I'm not going to have time to belabor this point, but we were using what's called general transit feed specification to understand the spatial layout of these stations. So we use these GTFS maps or graphs, which you can see on the right-hand side, in order to build journeys and to understand what sign or what text I could anticipate you finding using OCR on your own private mobile handset, okay? So you would download Commute Booster on your personal cell phone, you would open it up. We're basically using text recognition, and we're comparing that to the text we anticipate you to see, and then it becomes a game of Marco Polo, if you're familiar with that game. It's, are you looking at the right sign? Are you looking at the wrong sign? If you're looking at the wrong sign, orient yourself to the right sign, and then follow that sign. And then we keep doing that over and over again, depending on the journey that you want to complete. Okay, let me play a brief video. This is live, a live feed from an end user in Brooklyn, New York. And you can see immediately I'm recognizing the right characters or the right text for this subway sign. And the augmented reality bounding box turns green, meaning this is a sign that you're supposed to follow. I'm given auditory and tactile feedback. And then as I complete my journey, I continue to layer on additional feedback, whether or not I'm pointing towards the right sign or towards the wrong sign, so I can course correct. Hopefully that makes sense. And again, you could see the GTFS and the journey delineated on that graph. Okay, I'm going to, again, show you a brief snapshot of the clinical trial we just finished conducting. This is under review, again, for publication. This was a clinical validation of Commute Booster in partnership with Lighthouse Guild, a nonprofit in New York City. We were navigating the 59th Street Columbus Circle station, one of the most complicated subway stations in New York, one of the biggest as well. We took a dozen blind individuals, blind and low vision, average age 62, 6 females, and I believe 4 males. This was set up as a within subjects design with 2 conditions. So we had Commute Booster as our active support, and then we compared it to Navalens, which are those brightly color-coded QR codes that I showed you briefly before. Bottom line, Commute Booster allowed end users to complete journeys faster, to find key signs more quickly. Users were able to act on that information faster or had lower latencies, which is really important. It cut down on false positive Commute Booster compared to Navalens. Commute Booster users stopped less, so again, less idle time in the overall journey, and they needed less help from the chaperones compared to Navalens. So again, performance, fantastic. Okay. Last but not least, we're going to talk about AI performance enhancement, a topic that we've worked on intently for the last 5 years. Really excited about this. The bottom line is that video quality matters. So many AI applications, images are acquired, they're immediately downsampled, and then they're compressed to reduce the amount of data that needs to be transmitted to improve inference time or round trip time if we're thinking about the whole journey for those data samples. However, what most people don't recognize is that image and video quality impacts AI performance. So when I'm connecting to AI services on a server, we need to consider how the video is transcoded for wireless transfer or wireless transmission. So this affects spatial resolution, frame rate or temporal resolution, or color quality, or what we call the amplitude of resolution. And you can see those differences here in some images from a lab member looking at pedestrian signals in New York, and how the image quality degrades if I look at spatial resolution on the left, temporal in the middle, and on the right-hand side, amplitude of resolution. Okay, so let me cut to the chase. I basically have 3 different options when I'm thinking about transmission. I could do nothing and just transmit raw video data. The problem is that I'm probably overestimating the size of my data channel, and then I end up getting all of these artifacts, and then guess what? My AI doesn't work very well. The other option, which was what most groups do, is that I can downsample a lot, compress a lot, and then I have basically a smaller amount of data to work on, which is usually faster, but guess what happens? I'm only able to detect a certain number of obstacles, as you can see all the way to the right. But what I really want to do is what's right in the middle. We'll call this strategic compression. So I can assess the size of my data highway and cram as much image quality as possible into that data highway, and then guess what happens? No interruption secondary to artifact, and rather than detecting a handful of obstacles that you can see on the right, bottom right, in the middle, I'm able to detect twice the amount of obstacles. Well, how critical is this for someone who's blind or visually impaired? If I'm walking outside right now and I'm using my meta glasses and I'm using this microservice, would I like it to detect 50% of the obstacles or all of the obstacles? Well, as a blind guy, I'd like all of the obstacles, okay? So this is how we do it. All right, so this may be a bit technical, but I thought it was important to highlight. So here you can actually see data traces. And what I have here on the pink is the overestimation. This is me doing nothing on the diagram on the top that I just showed you. The purple bottom line on the bottom is me underestimating the data channel. In the middle, you can actually see the data highway that I have available and me trying to fit the video stream into that data channel perfectly. A perfect fit between the bandwidth and the data that's being transmitted. Well, what does this look like? So let me put this in practical terms. Here I have some video feed from one of the wearables in New York City at our engineering school. On the left-hand side, you're going to see that video feed with no transcoding, just sent raw to the server, and you're going to see me fire obstacle detection. On the right-hand side, you're going to see me doing the transcoding that I need to, or that strategic downsampling and compression in the middle. Let me play this video. It should be very obvious right away on the left-hand side, I have artifact all over the place. So guess what? Your AI is not going to work, or it's not going to work well. It may work a little bit, but not well. And you're going to have a lot of upset end users. So here's where it gets even more exciting. You may say, this seems interesting thematically, but how much of a boost am I actually getting with this strategic compression? So now you can see here is a network simulation. You can see this sort of staircase on the top. Now in blue, we're using sort of a standard approach from Google called Google Congestion Control, or GCC. And in green, you can see our custom approach using a modified GCC pipeline, okay? Well, what does this matter? If I'm able to get closer to those staircases, it turns out that I can get a 40% of information boost as it relates to the amount of video that I can transmit at a higher quality. That's a 40% boost. And here's where it gets interesting. If I actually look at image quality through techniques like PSNR, which some of you in the room may be familiar with, look at the improvement I get in green compared to blue. This really matters. So for all the AI engineers in the room, think about image quality. Think about video quality, okay? It's really important to your overall performance. So let's talk about the future of personalized accessibility. AI systems have to adapt dynamically to user preferences, task demands, sensory profiles, and environmental conditions or context that I mentioned earlier. So what are some 4 examples to concretize this? We have to think about prioritizing output information. We have to think about understanding context and adapting accordingly. We need to think about delivering actionable feedback and integrating audio with haptic feedback depending on what's suitable and end user preferences. And we need to think about pacing information delivery and adapting to the user's likely cognitive load, okay? I want to reiterate that point. Adapting to the user's cognitive load. Really important, and we're doing some new work over the summer on these topics. Again, happy to talk more about that after this session. So what's the role of academic health centers? I was asked by Dean Pat and the organizers to talk specifically about how academic medical centers and health systems can help accelerate AI discovery. So first and foremost, I would argue that academic medicine is a discipline nexus. Academic medical centers, or AMCs as we often refer to them, are uniquely positioned to connect unmet clinical needs with technical innovation. AMC's mission extends beyond research, clinical care, and education, the sort of standard tripartite mission. It serves as a bridge between innovation and real-world impact, obviously a key theme of this AI summit. AI-enabled health and assistive technologies require close partnership between medicine, engineering, computer science, and, critically, the disability community. And here's a highlighted theme in a paper that is available for you, reference at the bottom and in the bibliography, talking about bidirectional immersion, or BDI, which is a strategy that can be employed for translational projects that require different skill sets. So BDI, from a definitional standpoint, is the attentional two-way exchange where each discipline learns from, influences, and is transformed ultimately by one another. So let me give you some more examples of this. So let's talk about engineering and medicine specifically. So we could have clinicians that teach engineers about patient needs, clinical workflows, safety, real-world implementation. And they can learn from engineers about technical capacity and capabilities, technical feasibility, validation, and scale. What about the engineers from their vantage point? Well, we could teach clinicians about engineering principles, AI capabilities, prototyping, and technical evaluation. And we can learn from clinicians through exposure to patients, care environments, and unmet healthcare needs. So what are the shared benefits between both disciplines? Well, solutions are jointly evaluated through the full translational pipeline. So what do I mean by that? I'm talking about technical validation, clinical effectiveness, and real-world adoption. So interdisciplinary training prepares the next generation of clinician scientists, engineers, and healthcare innovators. And the goal is to create a learning health system with integrated pipelines for development, testing, implementation, and continuous improvement of AI for good. So what do I mean by this concept of AI for good? Well, academic medical centers play a key role by being uniquely positioned to unite clinicians, engineers, scientists, trainees, and the disability communities to accelerate responsible innovation. So the idea formula, again, does it work? Technical validation. Does it help? Clinical validation. And lastly, could it scale? The implementation science. So the outcome is AI that is equitable, responsible, fair, and anti-ableist. So the key takeaway, academic medical centers should not just adopt AI. They should help shape, validate, and steward its equitable deployment. Okay, so let me wrap this up, and I have, 3 minutes left, so I'm doing pretty well on time. All right, closing vision. I'll leave you with these remarks. So the role of AI. AI is transitioning from a technological novelty to societal necessity. The question is no longer whether AI can perform a task, it's whether AI can create meaningful human value. AI-enabled assistive technologies is becoming critical participation infrastructure. I hope I've convinced you of that this morning. Access to information increasingly determines access to opportunity. I want to repeat that. Access to information increasingly determines access to opportunity, and we need to create opportunities. We have to shoulder this as clinicians and engineers and move it forward into the next stage of progress. Mobility, communication, education, employment, and healthcare are inseparable from digital access. The next generation of AI must earn trust, not assume it. Solutions must be reliable, affordable, scalable, and inclusive. Solutions must perform under uncertainty, communicate their limitations, and respect human agency. Solutions must include lived experience and invaluable expertise. Academic medical centers have a responsibility to lead, bridging engineering, clinical science, and disability communities, and leveraging bidirectional innovation. Translating innovation, the translation to real-world impact across that translational pipeline. And lastly, advancing AI must be grounded in equity, accountability, and anti-ableism. I thank you so much for your time, and I would love for you all to stay in touch. So please reach out on LinkedIn or on Twitter, and here are all the references available for you. Thank you so much.